So our final speaker this morning for this morning's part of the symposium is Dr. Vincent Moore. Dr. Moore is the Florence Pierce Grant Professor of Community Health in the Public Health Program at Brown University. Dr. Moore earned his BA in Philosophy from Boston College, a master's degree in Rehabilitation Administration from Northeastern University, and his PhD in Social Welfare from Brandeis University. Dr. Moore was one of the creators of the minimum data set, which is used for nursing home resident assessment. He has developed several summary measures using MDS data to characterize nursing home residents' physical, cognitive, and psychosocial function. These have been used in the analysis of quality of nursing home care in the U.S. and internationally. Dr. Moore's research has been supported by more than 30 NIH grants and funding from the Robert Wood Johnson Foundation and the Commonwealth Fund, among others. He is the recipient of a prestigious NIH Merit Award and the author or co-author of over 400 peer-reviewed publications and more than 30 chapters in books, including most recently being an editor of Challenges in Regulating Long-Term Care Quality and International Comparison, published in 2013 by the Cambridge University Press. Dr. Moore is currently the PI of a large program project from the NIA titled Shaping Long-Term Care in America. This project examines the impact of the changing state Medicare policies on long-term care providers and the patients they serve. Collaborating with colleagues from Dartmouth, Dr. Moore has documented regional variation in hospitalization rates, including end-of-life transitions and the use of hospice and palliative care. He will share some of his research findings and their implications with us in his presentation entitled Hierarchical Data Structures to Evaluate State and Federal Medicare Policies. Please join me in welcoming Dr. Moore.
So I've given enough talks in places I have conflicts of interest. I do work in long-term care. I also am on the board of various organizations that provide services to the long-term care industry, but nothing I'll be talking about is related to products here, so I just want to let you know. Acknowledgements, the work I'll be presenting is an omnibus of a bunch of different kinds of studies that we presented from multiple grants, chiefly the program project that Dr. Ottenbacher mentioned, but also from various things. And also we have data use agreements from the Centers for Medicare and Medicaid Services. None of this is possible without the data that they make available to us as part of these studies. So, what we'll do is a little background sort of on the data issues and broadly speaking, and then how you can think about how good the quality of the data are for doing policy analysis, what policy analysis means, and how. And then I'll give you a couple of policy examples of policy evaluations. First, case mix reimbursement, and a couple of little slants on that. And secondly, looking at the impact of Medicaid payment for nursing home care. And these are just examples of the kinds of things you can do for policy analysis using the data structures that I'll describe. And one of the points I really wanted to make is the notion of using alternate units of analysis for doing policy evaluation and policy work, because that actually gives you a hook on some methodological ways to deal with problems of endogeneity. And then just some summary about future directions and also some advice, I suppose. I guess that's reasonable. So, claims come from not just Medicare, they come from Medicaid, they come from health insurance companies, they come from all different sorts, and it's basically they're a way to track the pattern of use of people engaged in the healthcare system. It's fundamentally numerator data. And as numerator data, it has all of the problems associated with numerator data. That is, only sick people use care. I never use care. I don't like to use care. So I'm one of those people that, you don't want to ever generalize to me because I don't do it. I don't like it. I like to study it. But it's basically numerator data, and it's only powerful insofar as you can link it to a denominator of some sort. Sometimes the denominator is within the data. So you have a nice enrollment record like Medicare. It tells you every single person who's in the Medicare file or Medicaid is a little different because you move in and out, but Medicare is a nice population. But sometimes you can take numerator data and use an external denominator from census, and that also has huge value as well. But the numerator data is only valuable insofar as it gives you a denominator, and of course to do specific examinations for exposed versus differently exposed. So the claims data, however, because they're numerator and because they're located and they're identified to an individual has a location in time and place, you can aggregate them up. And that's a critical thing because all of a sudden the numerator data become numerator data characterizing providers or characterizing areas where you have counties or zip codes or what have you. And that, again, provides another kind of very substantial value for understanding these data. And they also, for a person, you can actually then look at an individual's trajectory as they move forward. And that is also really great in terms of the linkage so that you can begin to put together a profile of where somebody is on any given day. Using these data, it's really makes it possible to look at the impact of states' policies, because the states are relatively exogenous. The policy changes are not because of you and me. They're because of something else that's happened. Might be by the cumulative effect that you and me are having, but it's not because of you or me. So if you ask the question in the right way, you can actually use the policy changes as a way of, as a sort of a natural experiment, which I'll be talking about. Historically, and I did a piece for National Institute on Aging. They had a book, they were doing an electronic book, and we actually put together a sort of a history of some of these things and went way back and tried to think about where the initial linkages come from. But original linkages, they come from the CDC. This is basically event-level data on illnesses, etc. And you can link, ultimately, the first linkages that ever occur is birth and death records. Very important, but it's the same kind of thing. You can then, the next big thing, the University of Michigan was doing this in the 1960s, assembling for the whole state all hospital discharge summaries. And because it had all hospital discharge summaries, has all of those advantages of that time, and over the time, Michigan has been doing this forever. Rhode Island has been doing it since the early 70s. I remember when I got to Rhode Island in 1980, we were able to actually do these kinds of linkages at the zip code and ultimately at the block group level to look at whose and where hospitalizations are occurring by what kinds of people. And so that's another possible. And then, of course, once you have the claims data, you can actually really move further in terms of linking individuals who have part of an enrollment record, and you can link that to individual service claims. You can then have the service dates come across in particular sequences, and you can then link claims to providers, and then you can link providers to particular areas, defining their catchment areas in one form or another. So data systems that are built on Medicare or Medicaid in post-acute care, we'll follow up from what Ann was talking about, are fairly broad. You start almost always with a hospitalization, not entirely always, and then people have this sequence of events that occur thereafter in the various forms of Part A claims from skilled nursing facility, home health agencies, or rehab hospitals, or LTACs, or what have you, or also hospice, because post-hospital, lots of other things happen to people. So these claims can be constructed hierarchically, going up, summarizing about groups and areas, or they can actually be for the single individual going forward. One of the things that we have constructed is something called the residential history file, which for every individual, it's possible to actually identify where they are, relatively speaking, on every single day. And so you can actually link together the from and to of every single claim. You know you have an outpatient bill, you know where that person is, you know you have a Part B claim. The Part B claim now says that you have a place of service where that is rendered, and so you know where that person is on that day. And when you bring in information from the minimum data set. If you're a nursing home resident, you can actually figure out where you are in between during each of these assessments. And this sort of individual history is possible to then say, oh, now let's look at all the people admitted to, let's say, for example, a nursing home, going from hospital to some particular setting, a post-acute setting in, let's say, Wisconsin. And then you can look at all of those people in 2000 and say, well, what is their entire experience for the next 180 days happen? And so you can basically, one of their experiences might be death. And so you could actually see of all of the 100,000 people who enter this system, how many actually die over time. And you see that accumulated, and you can also see how many people are in the community. And so you see an entire population of people moving through. And so we have a couple of papers using that technology. And the residential history file, I was telling Jim that it's actually being used now by CMS as part of their structure for actually making files for individual users using that approach. And it's a really great way to actually concatenate the data, creating trajectories. I'm here to talk about nursing home data because in some sense, at the population level, we were able to, in response to the National Omnibus Budget Reconciliation Act of 1987, which was the implementation of the Institute of Medicine study on nursing home quality, which recommended that there be a minimum data set or a resident assessment instrument which would characterize patients' functioning for the purpose of actually identifying what the appropriate care was for that person. So that was first done in 1991. It went into effect. I was involved in the team that helped build it. A second version went into effect in 1996 with some updates, more data, and it includes an admission, an annual assessment, a quarterly update of that assessment, and then periodic reassessments if there's a significant change in the person's condition, and at a minimum, a discharge record to indicate that the person is no longer there. Lots of data analysis we did, that wasn't always there. Since 1998, those data have been computerized, and they're actually required to be reported as part of payment, ultimately as part of the Medicare payment, but it's computerized for all events of all sorts. And since basically 2011, a revised version of the minimum data set for resident assessment has been put into place. And this one actually includes the required interviewing of the patient as part of that process, and we're working with those data now. But so this is just long historical trend, and so even though the data elements have changed somewhat, the from and to and the ability to track someone's history has remained constant over that whole time period. So this is what the data look like. This is old. The states have actually relatively little. The states don't have that much function anymore, but basically at the bedside, the data are collected, it's transmitted up in some sense through now almost all nightly download, and it goes into the big database in the sky, and then I pull it out as often as I can. This is what the MDS2 looked like. These are the functional status questions. How much support do you need, and how much help do you get, and are you able to do X, Y, Z independent? And this is what it looks like in the MDS 3.0, which used a lot of the same kinds of measures, but they made some sufficient changes so that you can't really equilibrate the two sets of measures. So there are about 15 million of these things that happen every year. Maybe that's probably an underestimate. I've actually never counted them. Most patients on any given day are long stay patients in nursing homes. There are about 16,000 Medicare, Medicaid certified nursing homes in America. On any given day, most of the people, about 1 million, are long stay. They tend to be there for a while. But most of the patients who ever walk through are short stay. So there are something like 3 million, 3.5 million unique individuals that will pass through a nursing home at some point, a Medicare and Medicaid certified nursing home. So most of them are there for a short period of time. So it's a classic stock and flow issue that you have, which used to be there with hospitals, but now every hospital discharges all of its patients all the time. Now nursing homes are what hospitals used to look like about 40 years ago. These data are matched to Medicare and hospital and SNF claims, and we've also matched them to Medicaid data through the Medicaid Max, which is a national Medicaid data set. So among the MDS records, when we do this matching, in 1998 when we started this, 1999 when we started this work, the matching was much, much more difficult than it is now. Now, Medicare ID numbers, Benny ID numbers are much better than they used to be, and so CMS actually does all of that for you pretty much all the time, and it's only for the last year or so that I've gotten my computer guys to stop sort of saying, oh no, I have to worry about matching all these things perfectly, because we used to have to do that in the past. So right now the matching is virtually perfect for people who are over 65. It's much different under 65. The new research from the MDS 3.0, we've just completed the proportion of the correspondence between a discharge record that goes to that shows that somebody's going to a hospital and a hospital claim or an observation stay claim is very high. It's like 95, 96%. And so it's really, this is very high quality matched data at this juncture. The data are fundamentally hierarchical. So as I say, we start with the state. There we go. All right. And the state is sorted by county. Of course, then you've got a facility. And then the facility has individuals here. Some of those individuals will have a hospital claim. Some of them will have multiple assessments. And you just concatenate on. And when we concatenate on, this is an example of the application of this residential history file to the tracking of individual transitions over time. And so here we first have deaths, and then we have people go home. And these are all the different outcomes, all of which are identified. This is just the first transition. Then people begin to cycle back over and over and over, and the number of different cyclings is only limited by your imagination. The data are relatively reliable. There have been a whole bunch of different inter-rater reliability studies, generally pretty good comparison when you compare them to a research nurse. There is interfacility and particularly interstate variation in terms of whether the errors are more in one direction or the other, more inclusive or exclusive, or causing or not. The crosswalk on certain validity instruments that had been done with things like activity of daily living or cognition or hospital-related diagnoses are okay or relatively good. The mood and behavior ones are less good in terms of their past historical work. Even the new MDS 3.0, which actually asks the patients questions, even though they're asking patients questions, the prevalence of certain of these mood state disorders are less than if you were actually administering them by a research person on the outside, even though they're supposed to be asking the same question. But in general, the data are valid with respect to construct and predictive validity. We get pretty good models for predicting hospitalizations, pretty good models for predicting mortality, and really good survival distributions, and the data behave the way they should stay. You know, for a variable that says X, and you think X should mean X, Y, Z in relation to a particular criterion, it actually does work that way. We've done a bunch of different things. We've just finished, we've got another paper in progress now using the MDS 3.0 data, looking at sort of the crosswalk between the claims and the minimum data set data. This is just one which will, I'm looking at the positive predictive value. This is the Medicare hospital diagnosis, and this is the diagnosis on the MDS. The diagnosis on the MDS is a little bit different than the diagnosis on the acute hospital claim. The acute hospital claim is whatever the hospital happened to write down, up to 8 to maximize their reimbursement. On the nursing home side, they don't get paid for the diagnoses, but they're supposed to be active diagnoses, so there's supposed to be a crosswalk with an active diagnosis and what the nature of the drugs people are taking or the therapies they're getting. And so the count of diagnoses on the MDS might be actually fewer than on the Medicare claims. So this is the framework we've tended to use in our sort of use of these data. We have data from every single nursing home, basically, if you entered a nursing home in America since 1999, I have all of your Medicare claims in our computer systems. And we have them funded under various sources of NIA data. And we're essentially asking this question, what's the effect of a state policy on long-term care on providers? Because the policy is affecting the behavior of the provider. And the behavior of the provider then alters how they perform organizationally. And that in turn has an effect on the outcomes that patients experience. Because the state policies don't have this effect. They're always through this, or they cycle by making market forces, which then alters which providers get into the game, and that then will look at the overall organizational performance. The one way that this happens more directly is also indirect, is that state policies can affect who will enter a nursing home or not enter a nursing home by virtue of the availability of alternatives. So, a couple of examples. The shift to state case mix reimbursement. Case mix reimbursement is you pay more for patients who are sicker. Makes sense. We do it with hospitals all the time. States introduced case mix reimbursement, have been doing that for some time. By 2009, about 35 states were using case mix reimbursement. What's called resource utilization groups, which is sort of a different approach, a functionally based approach to dealing like DRGs. It's relatively no diagnosis at all, just mostly functionally based. So what we did was we wanted to understand what's the effect of a state introducing case mix reimbursement on the acuity of the patients entering it. We use data from the CMS inspection, nursing home inspection survey, which is done every year for every nursing home, more or less. And then we created aggregated data from the ADL impairment measures and high-tech treatments, and we created a variable out of the state survey. And then using the MDS, this minimum data set, we created admission and annual resident case mix cohorts to define sort of the acuity of the population entering as well as the acuity of the population on any given day, the prevalent population. So we did separate analyses of these two different sets of data, asking a similar kind of question. We used a facility fixed effect regression, so we looked, as in same store over time, which facility was looking at what, so every facility had to contribute at least 2 years of data to the data sequence. 7 states during the time period of interest introduced case mix reimbursement from 1995, and then 3 between 1999 and 2002 or so, and so forth. And then we control for various facility characteristics. Just briefly here, the top line, you see that's the introduction of case mix reimbursement or case mix payment in that state, and it's basically the delta when that when that policy is actually introduced, and it's associated with an increase in the sort of the nursing home survey case mix index, about 1%, and then here are the patient levels. This is for the 4 years of data, and so different, about twice as prevalent or twice as strong an effect on in terms of the case mix reimbursement on the admission cohort, that is the new people, as the prevalent cohort. And then some of these other factors down here also matter in terms of calendar year. And yeah, that was the one for this one. Okay, so with the adoption of case mix reimbursement, essentially is found to increase the case mix acuity in a facility by 1% for the long stay population and by 2% for the new admissions. And so this sort of, it makes sense. That's where you'd see the effect, because The prevalent population is always going to have the sort of people continuing to stay there. And this increased in both the data sets, in both sets of measures, and we also found it was a stronger effect in facilities that had a higher proportion of Medicare patients, so they were better able to respond and therefore take the folks. So it told a story that actually made sense. And also there was, we thought there might be a greater increase in acuity in more competitive markets in terms of the competitive nursing home markets, but that was not the case. So the next thing we said is that, so let's study how this affects the actual organization, not just who comes in, but actually how it goes. And so state case mix reimbursement is often introduced with some kind of a new data system or increased attention to filling out forms. We always remember this from when DRGs went into effect in hospitals. Hospitals all of a sudden devoted a lot more money to coding. So nursing homes also devoted a lot more money to coding. So we wanted to actually look at that, because when we looked at things, we saw case mix acuity going up, but we actually saw that nurses on the floor, that proportion in the state data, weren't going up in the nursing home information. And so we wanted to say, well, what's going on here? Is it that the nursing is going up to accommodate this is administrative nurses? And so that's essentially what we want to look at in terms of this behavior. So the policy variable, again, we're looking at is case mix reimbursement. Again, the delta when that changes. We're looking at the Medicare payment rate when it went into place. And we also have, in the midst of the data series, the introduction of Medicare prospective payment, Medicare case mix reimbursement, which we would expect to have a differential effect as well. But with Medicare policies, they're universally implemented, whereas state policies are only conditionally implemented depending on what state you're in. The outcome is administrative nursing hours per resident day. This comes from the annual survey, inspection survey. And we looked at nursing home data for 1997 through 2004. So I'm actually getting all of the right numbers here. We don't have, we're looking at this for just urban freestanding data, and freestanding nursing homes are not part of hospitals. The problem with nursing homes that are part of hospitals is they mix up the data as to who's employed by the nursing home and who's employed by the hospital. So we wanted to have that part relatively clean, and you get to see that. We used a facility fixed effect, controlling for market and facility time variant covariance as well. Just to show you that we actually did see, this is a box plot. I love box plots, they work very nicely. And the unit of analysis here is the facility. And so you see that over time, and most of that delta is happening right here where prospective payment was going on at the Medicare level. And if we could, again, you can divide the facilities that are in the states that have no change in case mix. They didn't do case mix. There was no change. They always had case mix throughout. And then here's where we see they had case mix pre, and here they only had case mix post. And what's the difference in this two? So that's a very nice descriptive way to put these kinds of data together, as opposed to just putting all this stuff in a fancy big regression equation. And again, we see a really large effect of the introduction of state case mix reimbursement on every specific model. Each model has different kinds of covariates in it. We see a really big effect, as economic theory would suggest, in more competitive markets. There's even more increase in the number of administrative nurses because they need the money more to compete for the revenue. We saw a significant interaction for the introduction of Medicare PPS as a function of the size of the nursing home. It also sort of made sense from the point of view of what economic theory would say. So we see this increase, 0.21 to 0.24 over time. States introducing case mix reimbursement had about a 5.5% increase on average in this, and it was a stronger effect in the face of, after Medicare PPS had gone into effect. There was no effect of the Medicaid the payment rate, so they did it just as much in New York as they did it in, let's say, Mississippi or something like that, where the payment rates are quite different, but both of them had changes in case mix reimbursement. So the next example is using the whole thing, looking at Medicaid payment rates on quality. And so it's a long history of quality problems in nursing homes. It goes on forever and ever, and it continues to be a big issue. The Institute of Medicine report, which is the thing that stimulated the development of this resident assessment instrument, they made lots and lots of recommendations, which were actually implemented over the course of the next decade after OBRA 87. Medicaid payment rates are constantly the industry constantly complains that the payment rates are far too low, and there's lots of data to suggest that in fact payment rates are below the amount, whether you use an industrial engineering approach to understand how much staffing is necessary, or whether you use a cost report approach. There is a lot of evidence to suggest that, in fact, Medicaid payment rates are below what they probably should be. They're a lot lower than Medicare payment rates. But they vary dramatically from state to state, far more than the cost of living variation is. And there is some data out there strongly that does suggest that higher pay is associated with better quality, but most of that is cross-sectional. It's sort of like nursing homes, the quality of nursing homes in New York, which spends about $300 a day, versus Mississippi, which spends about $125 a day, or Texas, which is another story altogether. It is, they're quite different. But the question is what does an extra dollar get you, which is the right question we want to ask. So this is actually 2009 dollars, and you can see there's been real increase in Medicaid payment rates over time. We looked at the cohort of long-stay residents of urban, non-hospital-based nursing homes who were 65 plus. That's about just under 10,000 nursing homes that were over time that we looked at this. There were about, just under about 9,300. We looked at residents' outcomes, and they were aggregated to the level of the facility the way you would aggregate like a quality measure. Now, we had patient-level data, so one might say, well, why? Why are you throwing away all that information and aggregating data up? It's because patients are in a facility, even though they're long stay, for relatively variable periods of time, because they're constantly censored by dying. Very inconvenient. They just die. And so if you try to actually follow each individual, you'll only get these little snapshots, and you constantly have this censoring phenomenon going on, making it really difficult to say, are you starting everybody at the same level to make sure that this is going on? It makes the analyses far more complicated, and from a policy perspective, you really care about how the dollars are affecting the facility to achieve an average improvement in quality, as opposed to how the dollars are affecting the facility to affect Mrs. Jones. It's a little subtle differentiation, but it is something that we played with. It just because also much more difficult, and it also empirically makes the data much more complicated because you're always having to deal with differential censoring rates because mortality becomes an outcome. And people are very uncomfortable dealing with mortality as an outcome in these kinds of analyses because it changes the parameter in terms of whether there's a state of death, state worse than death, et cetera, in the linear assumptions you made. So for us, for all these reasons, it was easier to think about aggregating up. So every facility had to have at least 20 observations before I'd actually get a measure of that facility. We had 4 outcomes we want to work with. We looked at restraints. We looked at new or worsening pressure ulcers. We did some risk adjustment for that. We looked at persistent, moderate to severe pain, that is pain at 2 assessments, 1/4 apart, that was still there, with some risk adjustments. and ADL decline of at least 4 points. Now, picking up on a point that Ann mentioned in her talk, these are long-stay residents, so that means that you have to be very careful not to over-adjust. Because if you adjust for the nasty things that they cause the anterior time, then you're sort of biasing the results in terms of how you work. So you have to be very careful about how you adjust for things from in these kinds of analyses. So I haven't had it yet. So we adjust for functional impairment and a certain selected diagnoses in the ADL decline. We adjusted for cognition and diagnosis for pain, and we didn't adjust at all for restraints. That was pretty straight up. We used a regression model and applied the adjustments and then aggregated the expected per facility the same way you would with a quality indicator. We had both linear and dichotomous measures, again, because we wanted to publish this in a medical journal. We said we're going to throw away all of the continuousness, because when you aggregate up to the individual level, you end up with a percentage, which is, what percentage can go from 0 to 100, and it's always a funny skewed distribution, but we can use different analytic techniques to make that possible. But we decided to actually present the main analyses as dichotomies, also because some facilities had 100 plus people, and some facilities had just 20 people. You'd have a slightly more stable estimate as a percentage rather than as having the possibility of being a skew variable, which you'd have 90% of the people, but there were only 10 people or only one person out of 20 that had the event. But we ended up doing the analyses both ways. The exposure was a $10 increase in the Medicaid payment rate, standardized in 2008 or $9. And then we also controlled for the introduction of case mix reimbursement. We controlled for the average acuity, admission acuity of the facility. All of our control variables were actually facility level variables. We looked at control for the percent of long-stay residents who are African American. We controlled for the average number of admissions per bed, so that's the put-through quality. So are you predominantly a short stay or predominantly a long stay? Because it's the character of the place that you're trying to characterize. We also want to look at the nursing home competition, that is at the number of empty nursing home beds in the county. And then we had an annual average wage index for the county as well in the census data, just to control for those other factors. We used a facility level logistic analysis using GEE, that is, we had a panel, so we had generalized estimating equations using logistic regression. We controlled for quarter baseline value of the independent variables, and we used robust standard errors because we had replications of the same individual facility over time. We used a fixed effect controlling for clustering within the quarter, and we did a whole bunch of sensitivity analyses given the findings in order to understand something about where a state began, where facilities in the state that started low versus high because of the heterogeneity of the payment rates to begin with, or where they began with. So this just gives you some baseline information. And this is the percent achieving the high clinical standards. So for restraints, it's what proportion of facilities had, I think, were restraint-free, or just 1% of people in restraints. And then the ones down here is the ADL decline is the blue line, and then the persistent pain. And this is a phenomenon that many of us in the nursing home world are trying to figure out what happened here, whether this is real or some other kind of phenomenon that happened in the mid-2000s. But that's the real unadjusted or unadjusted data. When we control for all of those other factors, we found that for ADL decline, there's an almost 10% improvement from quarter to quarter in the proportion of facilities that meet the sort of the standard threshold. For PU worsening, it's about 2%, and for persistent pain, it's about 5%. For restraints, has a very funny sort of anomalous inverse finding, and I'll show you why that is in just a moment. It took us a while to figure that out. It made no sense at all. It's one of the things you have to worry about when you have complicated panel data, and in the context of a significant secular trend. So we did a bunch of sensitivity analysis. We want to find out how did the best and worst homes fare over time. I won't spend as much time on that. We wanted to examine the improvements in the outcome as a function of the rate of increase in the Medicaid payment rate. That is, the states where the payment rate went up much more dramatically, was there a bigger effect? Because that would sort of give you the sense of there's something really going on there. And then we looked at into various subsets of facilities. I'm going to spend most of my time. So this is just, where you started. This is the ADL decline. And this is one of the great examples of classic regression to the mean. You start with a facility that has, the top quartile is having something like 27 or 28% of its patients achieving having a decline, whereas here you start with people, this decline is very rare, and at the end, it's pretty mixed. But that only tells you how things began relative to where they, relative to how things change relative to where they began. What you really need to understand is how things changed for select groups. So here we said, let's look at the high quality threshold for activities of daily living decline, looking at states in the blue that had the lowest rate of growth in Medicaid spending, and the states in the red had the highest state of growth. And we divided Medicaid payment rates into 4 different levels, growth in payment rates into 4 different levels. And so the unit of analysis here is again the facility, but we then sorted by the state payment rate. This group is the group, largely speaking, that had the highest rates to begin with. This group is the group that had the lower rates to begin with, and those rates went up more rapidly. And this is a really big change. And it's sort of one of those examples where you say, oh, well, a $10 increase matters more in one place than another place because of where they began. So we also, that's what I just showed you. Having an Alzheimer's or other kind of special care unit or et cetera didn't seem to affect this thing, or adopting such an innovation in care delivery also didn't seem to affect that effect. Now, for the restraints. Here again is, we get even the worst nursing homes had a massive reduction in restraint use rates over that time period. But again, with the Medicaid growth the lowest and the Medicaid growth the highest, these are relatively parallel, although you don't see the same kind of crossing that occurred on the ADL decline. These are both increasing, going up, so it doesn't seem to be a function of how much you're paying in that part. What we did find was states in the top and bottom quartile of Medicaid payment rates both reveal a significant effect of the payment rate increases on reducing the restraint rates, about 8 and 10% respectively. One of the groups in the middle, where the states didn't increase that much more, seemed to have an anomalous effect. And this is sort of one of the examples of, in the face of a very steep reduction in restraint rates, using a GE or fixed effect panel study over time means you're just trying to look at the difference on these differences. And in the face of, even though you're controlling for quarter, it's really hard to get those estimates just right. And so our regression estimate shows an adverse, that is, the more you spend, the higher the restraint rate goes up. That really doesn't make any sense given the observational data, but it's affected by some states just in the middle. So you always have to be very careful in doing your analysis to actually look deeply underneath that to see whether there's a consistency that's going on. So, but basically the policy is a $10 increase in Medicaid payment rates. It translates into about a $2 billion a year extra, which basically translates into about a $2 billion a year extra increase in payment. And that actually does achieve an effect. This is about half the estimated shortfall that the nursing home industry at the time said that they were not getting paid by Medicaid. So you really have to ask yourself, what's it worth? What's a 5 to 10% reduction in the rate of ADL decline, pain, or pressure ulcers worth? And I don't know how to answer that question. I just know, since I'm kind of not a hospital kind of guy, I think to myself, well, this is clearly inefficient because we're clearly paying more to places that aren't improving because they were already at least at that level before. On the other hand, if you look at the level of inefficiency in the acute care sector or the number of diagnostic tests we're doing that costs us gazillions of dollars, who knows what the right answer is. So just briefly, an example of changing the unit of analysis. So sometimes the state policy changes offer, Medicare, the state policy changes offer natural experiments, but Medicare fee-for-service changes are sort of universal, and therefore, you're just looking at yes, no. Did you happen, not happen, and you're looking to see if there's a consistency over time, and you can tell a story. Sometimes if you change the unit of analysis, you can begin to overcome some of that endogeneity problem because you assume that there's nothing going on at that higher unit that might be affecting the provider's behavior in a universal way. Because, see, the hospitals or the nursing homes that respond to case mix reimbursement or that respond to, let's say, a Medicare imposed hospital rehospitalization penalty, the more competent places are able to respond more rapidly. And so there's endogeneity associated with the provider response. The individual patient is going to sort of go along with that, but you're interested in the provider response. So under some circumstances, you can actually get some estimate of this. So we looked at this in terms of the effect of skilled nursing facility prospective payment, which occurred in around 2000, on hospital-based skilled nursing facility closures, and what that meant for rehospitalization from nursing home. Big topic, it's kind of interesting. So 1998, prospective payment goes into place. There are about just around 2,000, a little bit over 2,000 hospital-based nursing homes. Over time, that dropped by more than half. And these hospital-based nursing homes all either got converted to non-hospital-based or closed. Bingo. Because they couldn't make it under prospective payment. The payment rates were too small. This is just to show you the number of nursing facilities that are hospital-based sort of went from 22 in 1999 down to 1,380 in 2006. But when you think about the average number of facilities, nursing facilities, within 22 kilometers of the radius of an individual Medicare beneficiary zip code, you can think about the zip code as where people are, we see that it stayed relatively constant for freestanding, but it dropped again by half. So if you want a hospital-based nursing home, you got to go twice as far. And the average number of beds, again, dropped by a third because the smaller places go. Okay, so they're more of a scarce resource as a function of geography and like an instrument, unless you think people are moving to the suburbs to be closer to a hospital-based nursing home or a non-hospital-based nursing home. Probably not. They might be moving to a cath lab, but not to a nursing home. And here's the consequences of nursing home closures on rehospitalization rates. Here's the fraction of discharges to a hospital-based. Boom. This is from hospital to hospital-based nursing homes. And here's the rehospitalization rate from a hospital-based facility, as that number's declined, but the rehospitalization rate stayed relatively steady. Rehospitalization from fee-for-service nursing homes started at about 17% and went up to about the 20-some%, as they're acquiring more impaired patients, They have a riskier profile, a more impaired population. So we compared changes in the rehospitalization of post-acute nursing home patients in areas that lost hospital beds and basic to those that didn't. And so for every 100 hospital-based nursing home beds lost, the rehospitalization rate of post-acute patients increased significantly. And aggregating analyses to the market level sort of makes it possible to get away from, yeah, it's a hospital-based and there are fewer hospital-based, and so, but what does it mean at the area? Because the outcome here is a zip code level rehospitalization rate. And so here we can see at the dependent variables rehospitalization rate in the zip codes. And so are you in a zip code that has 100 beds, per 100 beds, nursing home, hospital-based nursing home beds within this 22-kilometer radius? And we see a very significant effect regardless of how we model this. So the loss of nursing home beds over time resulted in, of these kinds of nursing home beds, resulted in an aggregate increase in the rehospitalization rate. So those are just sort of 3 or 4 examples of what you can do with these kinds of data. Obviously, future challenges are going to be significant. Growth of Medicare Advantage, it's now, I think, around 30%. That means that for every numerator, we don't have a denominator anymore, because we just have a really biased denominator. It's people who go to fee-for-service. And it's going to get worse because you're going to have all these Medicare Advantage for dually eligibles. And so actually we may end up with a hollowing out. The less sick and the sickest are going to go to Medicare Advantage, and the vanilla are going to stay in fee-for-service, I guess, I'm not sure, or the richer vanilla. The MDS and other PAC assessments are available within 1 or 2 quarters. I get the MDS data almost 1 quarter, a little bit more than a quarter, 4 or 5 months after the assessment is done. Medicare claims, I can wait around for 18 months for those claims. And if you care about reporting out to people who want to use that, or if you really want to understand what the effect of some bundling demo is, you want to know that soon. Because if you're at Medicare, you certainly want to know that soon. They're trying to accelerate the process, but it's difficult. There's also a very complicated world of the accountable care organizations and the bundling as to who's in what and how they're in, and how you understand what the effect of being in a bundling demo that's also next to an affordable accountable care organization. And so that's going to increase the complexity of these things. And in the bundling context, that's going to incorporate all of the issues around post-acute care. And so that's where the people in this room, if you're working with large data, looking at post-acute care, I would write proposals on this topic as quickly as you can. It is hot as a pistol to try to understand what's going on. This is particularly important because the most recent Institute of Medicine report on geographic variation said that, we got a lot of this geographic variation. Jack Wenberg and his colleagues at Dartmouth have been documenting for all this time, so on and so forth. But you know what? It's not about the hospital. It's 40% of the variation in Medicare area and variation Medicare area-wide Medicare spending is attributable to variation in post-acute patterns in spending. What happens afterwards, that 90 or 180 days. And that is a really big deal. Understanding that, understanding what those dynamics are, is really going to be important. And so I guess finally, later retirement is also going to, I have no idea what's going to happen here. People are going to be rapidly retiring. There's this piece in this morning's USA Today that Americans, there's a survey that most Americans are going to now work until they die, or can't work anymore. So, that's not like the French. So, but finally, I guess the availability of these data really make it possible to ask, unique questions about policy evaluations. And, I was telling Jim earlier, my students now, they come to us and they say, oh, I'm not just looking for an instrument, I'm looking for regression discontinuity, I'm looking for this kind of fancy stuff, because they're used to having these data available, where they're actually thinking about, so for example, if you were to actually look at what time of day, whether someone is, what somebody's length of stay on a Medicare stay, whether you're admitted at 11:59 or 12:01, because Medicare counts just days. So one of my students, he's been obsessed with this regression discontinuity design, where you can see that. And the work we've done, he did under his direction, we actually see increases in diagnoses associated with iatrogenic causes, because length of stay actually is longer for people admitted at 12:01. And so therefore they're in the hospital longer to get something else happen to them. But that's the kind of thing that you can actually take advantage of. While there are lots of limitations, and please, everything that Ann said about data, it's absolutely true. You cannot be mucking around with these data unless you really, really understand them well. And even more than understanding them well, be incredibly suspicious. That's the best. Have your suspicion antenna up really high, because people make all kinds of mistakes, and it's fine if it's error, but it's deadly if it's bias. And the more complicated and complete the data are, the more you can actually begin to detect some of the bias. Bias is a function of the individual patient. A bias is a function of the individual facility, and it's the area, and it's the state level. So when we do basic, cleaning, we sort of begin to roll it up. Yeah, there's missing data at the individual level and distributions at the individual level, but you say, how much does that vary as a function of facility? And the next level is, how much does that vary as a function of county or state or otherwise, and proximity to hospitals or otherwise. It's really important. But for all that, once you know the data and the data set, you can take advantage of all of these different exogenous forces that are really important. And as I said before, in this world of post-acute care, it is really hot and important and extremely complicated. So more than just the hospitals or the ambulatory care, this actually makes a lot of difference, understanding exactly what these transitions are. So thank you very much for your time.
Well, thank you.
I guess I didn't understand when you were talking about your first example, whether the case mix increase was an artifact of people just upcoding or whether there was a real case mix. Could you tell the difference? Or?
That's a really great question. So one would think when you put both these examples together, one is the actual real quote, the acuity, the measured acuity, and the other is the increase in the admin nurses who presumably are doing the coding. So the one thing one could look at is, and we have done this, is looking at things, characteristics of the population admitted that on parameters that are not included as part of the RUGS distribution, and for those things we also do see some level of increase in acuity when it's not just the RUGS case mix index. And we do see that whether we get the exact same estimates, it's not always the same, but we do see a pretty substantial increase in that, more on the admission side than the resident side.